Good afternoon, everyone, and welcome to today's webinar hosted by the First Illinois chapter of HFMA. The topic for today's webinar is the new world of healthcare. I'd like to welcome today's guest presenter, Lyman Sorenberger. Lyman is the Chief Healthcare Strategy Officer at Capio Partners. Prior to joining Capio and forming LGS Healthcare in 2013, Mr. Sorenberger was the Executive Director of Revenue Cycle Management at Cleveland Clinic Health Systems. Prior to that, he was with the University of Pittsburgh Medical Center for 22 years in leadership roles for their revenue cycle management groups. Mr. Sorenberger is a member of HFMA, ACHE, HIMSS, ACA International, and the chairman of the ACA Asset Buyer Committee. So without further delay, I'll hand the call over to today's guest presenter. Lyman, please go ahead.
Hi, Nikki. Thank you. And thank you to the group for joining this session. And I think we have a lot to discuss, and I'm sure that this is a lot to compress in a 1-hour conversation with the group. So I hope I'll give you some insights as to what I believe are our challenges for 2018 and going forward based on our historical performance. So with that said, let's take a look at what our agenda is going to look like today. We're going to talk about the mystery of healthcare reform. And basically, that's ACA and, Donald Trump, new president, what would it look like? What would patient responsibility is now as the number 3 payer in the industry? Should you insource or outsource your revenue cycle? That seems to be a strong question in the industry as to what you hold to your breast in terms of, my experience in 28 years on the provider side. What do you keep in-house and what would you consider? What are the new reimbursement models that would be a challenge for you in 2018 and going forward? And then, enhancing patient population health, or I'll add that new term that we're all trying to understand what it means, consumerism and the patient experience. And then we'll do the questions. So our objectives today, where's healthcare in the industry today relative to constant change? The 3 key lessons learned from the session, where the industry is today and where we're going in the future, and how are providers, patients, payers responding to those changes. And the initial responses to healthcare systems vary with each challenge. So with that said, there's 2 guiding principles on this presentation as a webinar. Don't shoot the messenger. I'm just giving you facts and a lot of factoids. So if you have a pen and paper, I suggest you keep it out because I'm going to give you a lot of statistics that I think will add a little, gunpowder to your messaging with your leadership, internal and external. So the mystery of healthcare reform, and I won't spend a lot of time on this in the interest of everything we're dealing with in this particular presentation, but if you look at Obamacare, it was a funded program. It was somewhat punitive from what you could hear from the politics of it, meaning that it was a mandate. And then there was a premium cost associated with it. What ultimately happened, though, is, President Obama thought that ultimately the age group of like the 26-year-olds and so on would, complement the sicker or aged population in this millennium. And then the assumption would be that if you remove pre-existing conditions and protected those patients, then that population would help them. And then maybe the fifth assumption was the underinsured would decline and we would have universal coverage with 17 clinical programs. What happened under Trump was he wanted to repeal and regress and blow it up. And that has been a challenge, as you know, and with the news and the media. And his challenges were basically blow it up and start it over and fund the program. And there would be no subsidy that Obamacare offered under the original ACA. There was no geographic consideration to whether you lived in New York or whether you lived in Alabama and the cost of, for care in that particular environment. And there was a sense that it protected the healthy and the wealthy, but not the sick and the impoverished. And so from that, I want to share with you a couple of factoids that I believe that, you know, Obamacare changed to Trump care. So first of all, the first action was that President Trump said he wanted to repeal and replace, and that didn't work well. So recently, what he really had shared with us was the fact that he wanted to chisel at it a little bit in 2018. Because that did not follow through, what he basically said was that more patients will not have the same coverage, but under a better cost prohibitive manner. And that would mean, from his means, would be that there would be less preventative care. And what does that mean? It means that, you know, under the original ACA benefit design, 17 benefit designs would be out there, and under Trump there would be only 10. And those 10 would exclude things like mental health, OBGYN, etc. That was probably a complaint under Obamacare, where a 90-year-old woman said, I'm paying to sign up for an exchange, and I don't need OBGYN, or I don't need pregnancy testing, etc. So that's been that kind of balance. But if you look on beyond that, what are his 4 changes? One is pre-existing. There's been a lot of discussion around that. Will pre-existing be in his protocol under our new president, or will it not? His ultimate response is, it will. But when you look at it, ultimately, it will cost you more at the end of the day if you have a pre-existing condition. And I'm not being political about this, but it's a fact of the matter that what has been presented so far in his vision for 2018 would be something that any provider needs to consider. And it could create a monopoly as you move across state lines. On the benefit design side, it's very simple. Obamacare included everything, good or bad, but you know, Under the Trump regime, it's 10, and even less under his new repeal. And we'll talk about that a little bit more. The subsidy, if you look at what he presented as a subsidy, there is none anymore. And that could cause a pause or concern for the population that assumed that they were going to be compensated as a byproduct of the fact that they could not afford to pay. And then I think the last one is the enrollment process. It's kind of, scaled back, and they can option or to waiver, and then they could purchase something less than the 10 options under the Trump plan, and that would mean for providers that they would have to reconsider understanding equity and benefit design. So in summary, the costs should be lower. There's smaller business requirements now under Trump's plan, and they don't include things like, medical device and tanning and everything else would have a penalty associated to it. And then beyond that, it can move beyond the state elements that you're required to. From a cost higher, from a provider perspective, that you need to recognize is, there might be more chronic illness out there in the industry, and that's why Obamacare probably failed, was they didn't take in anticipation as the more sicker patients signed up for ACA. And then as we move into the next millennium of patients getting older, et cetera, beyond that, it's something to consider from a cost that will be higher as patients get older, maybe sicker, live longer, et cetera. Will the cost be more to your organization? So in summary, I think that Obamacare is not going to be able to blow it up, but I truly believe that his intent is to kind of whittle at it and make it appropriate. But from a provider lens, we all need to recognize it may revert back to the old school of benefit design and understanding what that really means. So what you really see, in summary, trailing behind Medicare and Medicaid, patient responsibility is now the number 3 payer. And that's after Obamacare and where we are with Trump care. And some statistics to call out: 20 million Americans are currently enrolled in high deductible plans. 1 of 5 have deductibles of $2,000 or more. It costs 3 times more to collect from the patient versus the insurance. And 34% of consumers pay their medical bills late. Medical debt is the primary cause for personal bankruptcies in the industry today. This is a simple slide that you probably all know as providers that recognizes that, patients are willing to pay early on from a semblance of what their balance due is, and then as the balance grows, it's a stronger challenge for them. So patient financing is a huge element in the industry around helping our patients around consumerism, and we'll talk about that a little bit more. So the American Hospital Association reported this as uncompensated care. That means that since 2011, you know, uncompensated care would move from 41 billion to 72. What actually happened under Obamacare, due to the Medicaid expansion in non-expansion states, that it came closer to 59 billion. So let's talk a little bit more about patient responsibility, which I think by definition should not be called self-pay anymore. It should be what the patient owes, because self-pay has dwindled under Obamacare, and it may grow under Trumpcare, as to my former slides, but there's nothing to be known about that. But when you read articles around self-pay, be cognizant of the fact of whether they're talking about true self-pay and they have no coverage versus they are underinsured with high deductible plans. And these are facts from HFMA. 81% of true self-pay responsibilities are never recovered. That means they have no coverage. 55% of patient financial responsibilities are never recovered. Remembering that definition around the fact that they are underinsured, not uninsured. And then historically, hospitals have written off 3 to 5% to bad debt, and today it's 7 to 9%. And the majority is the underinsured. So to that little point, self-pay is not going away. So insource or outsource? Let me go through these bullets in the interest of my peers, and coming from the other side of the fence on the provider side for a number of years and thinking, I will never outsource. I am the best practice and I can do it all right. I have changed my paradigm for various reasons, but I ultimately believe that for all the right reasons, you could insource, outsource, or offshore. And we've all been guilty of the fact that we can do it better at the lower cost to our bottom line. I've taken on a little bit of different mentality that says there are certain segments of the business in this industry. Let me use out-of-state Medicaid to my peers on this call. That is a painful experience. Credentialing, pursuing it, and pennies on a dollar. There might be a great vendor that can help you with that. Let me use early out. You might opt to do that in-source, and that might be a perfect science, but it's all about your ROI. It's how you value the proposition of whether you could repurpose your employees and outsource it at a lower cost. So that element is something significant that I never thought I'd be speaking to on this call to anyone or in the industry. But I think it's all about that vendor relationship and finding the right partner, not vendor. And I mean that in the sensitivity of a vendor to me is someone that you just want to use supply chain and legal to bird dog. A partner means that you found a relationship. So here are some of the industry best practices that are out there that I have been exposed to. Same-day appointments and access, and they are challenges. So same-day appointment doesn't mean you always get paid. So for my providers on this call, you can promote a same-day appointment, but it doesn't mean you're going to get paid, because the insurances and even CMS has their own regulatory rules around how long to authorize it. So bring them in-house, ambulatory, ED, or inpatient, but recognize that there is some sensitivity that going forward with that type of strategy will have some costs associated with it. Transparency. That has a lot about consumerism. Patients want to know what they owe, but it's only going to get worse with the change in healthcare coverage and benefit design as to how we determine what they actually owe. And I'm kind of old school after 20-some years, but I definitely have been through the war wounds of you think you want to say to them what they owe, and that's what patients want from a consumerism standpoint, but it's a challenge for them. Patient financing. It's a new millennium. Not really new from the concept, and the verbiage, but what would that really look like? Would patient financing mean a loan program? Would it be a recourse model, a non-recourse model? What could you look at in the industry from that challenge? Because if you were branding yourself and trying to get patients to pay quicker at a lower cost, at a recourse or non-recourse model, the traditional payment plan does not work ultimately without some stipulation and some branding to that organization or your organization. And my next comment is, there's a lot of comment around, it's not big data, it's fast data. So for a number of years, a lot of terminology around, I need big data to scrutinize this. And a lot of people create a career around that. It's more about fast data. And then, as you would all know, as my colleagues, a lot of conversation around propensity to pay and quadrants. And what I mean by that is creating segments around the eligibility to pay. And I'm not talking about the Epics, Siemens, or anyone, and not to disparage them, but some, correlation between how a patient can afford to pay and not the basic of just a credit score or, their zip code. There needs to be correlations and discussion around that. And then, again, I'll stress again, collaboration. I want to remove the verbiage that it's a vendor versus provider relationship. It's got to be a partnership and a return on investment. And then consumerism will ultimately manage healthcare. And then at the end of the day, to my colleagues here, innovation is key to be a leader and not a follower. So macro, I'll go forward with this fairly quick because reimbursement models are changing as part of the industry challenges. Fee-for-service will not survive, as we all know, and that's what we all keep hearing. The bundled payment concept is probably already dying on the vine, for lack of better words. And that ultimately means that for the few bundle programs that are out there today, we're all hearing that they won't work. And the reason being around why bundle payments do not work, and I've gone through this with pilots and even at Cleveland Clinic, etc., is an agreement to a full payment under a bundle payment model doesn't mean that you will receive a full payment. So what does that mean? So it means that we agree to a hip replacement and it's going to be $5,000. And if you've done 20 hip exams, CMS can come back to you under the bundle program and said, from medical necessity, you only needed to do 5. So, you can do cha-ching off of what the bundle payment on a line item agrees to, and so that's been the challenge. The second one would be most integrated systems, as much as they want to be, provider and professional don't talk to each other as much as they could or should today, but the environment's moving in that place, but from a bundle payment perspective, they're not prepared to do that exchange internally or externally, and to make sure that everyone's paid appropriately. And providers will be sensitive about that, because if you think about what I just said around, they said you should not do how many hip x-rays. A finance person, revenue cycle person, going to a clinician saying you should not have done this many hip exams is a painful discussion. But the truth is, all you are is a conduit to the conversation that says, you can do as many as you want. I'm just here to express you may not get paid for it. And that's the challenge of bundled payments. Now, MACRA was trying to take on a little bit more of value-based care. And if you think about our history in the last 6 months, a push to EMR reimbursement based on being more electronically sound around clinicals. The challenge has been they have not connected as much with financials as need be, but there's still an emphasis around value-based care and population health. But when do you pull the trigger? So we went through ICD-10 as providers and delays, and when do you find it real? And then when you look at MACRA and say, should I take this serious, and what do I jump on? And when do I jump on and protect the interest of my organization as well as my cost? And what is our investment? And what is our strategy? So that's probably the challenge of MACRA. So again, this will replace, so far, the new bundled payment program. And how does the model work? So it's basically under MIPS or, the advanced payment methodology. And, talking a little bit about how I was challenged with what's the difference between the two. Most of the providers are going toward the MIPS. That is the more traditional model. You'll be paid based on quality and your electronic technology ability. And that's what has been promoted in the industry today. Nothing wrong with that, but everyone's being conservative, and about 80% of providers are going in that direction. Under the advanced payment methodology, you're being a little less conservative, and you're saying, I'm going to assume some risk. And that means I'm going to assume I will reduce quality and cost for reimbursement. What we all need to understand on this call is this program has been advanced as an incentive program, which means that you will get paid more if you report appropriately and you follow all the rules. What you need to recognize is ultimately it just means you're in a less punitive program. What do I mean by that? So it means that if you follow all the rules for MIPS, okay, if you follow all those rules, you'll get paid the same, but you won't be penalized, which means ultimately it's still a punitive program, but it means that you have to follow the rules. You're not going to get an incentive payment at the end of the day. You just will get paid at the same or more, or or less if you follow the rules. So it's kind of a strange model in the way it's been presented by CMS, but ultimately the bottom line is you are not going to be paid more unless you follow the rules. You'll get paid the same, but not less. And I hope that helps. And then reporting is key. There are some adjustments to the original requirements. So there's exclusions now that mean that originally it was 30,000 providers with Medicare. Now it's 90,000 providers that do not have to report. Originally you would have to do the EHR cert. Now you don't have to do under 2014. You can follow 2015. There's a small practice bonus, which means if you don't fall into the reporting requirements, that you can be bonused and under that circumstance. And then you're required 365 days for data, and the first reporting requirement was October 1st of 2017. So MIPS is not weighing or not adding any cost to the category, but know that here are the penalty thresholds that you would be up against. And they would be, again, as you would understand it or hear it, that it's an incentive program, but it's actually a disincentive program if you don't report appropriately. So you can do virtual groups, which means that you can work with others in your local common area and work on bonus programs with others in the industry. If you ever looked at 501R, they did something similar where they're trying to create collaboration. And on complex cases, you will be compensated more, but you will have to demonstrate that. So let's talk about a little about population health, patient experience, and the financial health of your system. And I'll just use a common term because I don't know if you know what population health is anymore, or patient experience, or the financial health of the system, but it's all about consumerism. That's ultimately what we're all talking about. And here's some realistic statistics. 9 in 10 consumers want to know their payment responsibility. And let me pull out something real quick because I have more around that statistic that I want to share. 75% of consumers expressed an interest in using mobile payment online. I mean, if you think about how your family members are becoming more technically savvy, and I'm in my late 50s, and I'm shocked at how my mother has learned how to use Twitter and has learned how to text. So, you know, don't let your barriers be that you assume that most don't want to touch it. There's a percentage that do not, and I have some of those, but 96% of payers say that they still pay providers via check. In 2015, 77% of consumers that they were confused by their EOB. Imagine that. Aren't we as providers the same way? And then from that, payers and patients are still confused. And 74% of providers see an increase in patient responsibility. 70% of providers reported it takes at least 1 month longer to collect from the patient. So, in emphasis to this particular discussion, I think from a consumerism, we're all talking about educating the patient, making them technology savvy, and helping them to be patient friendly. And I had a discussion with my CEO today, Mark Dietrich, and about kiosk. So I tried that program 6 years ago in the provider space. And maybe it was longer than that, maybe 10 years, I'm sorry. And it was not successful. Patients did not feel comfortable. They still wanted patient-facing. The industry has changed. Airports, 3/4 of us that travel are probably using a kiosk or something similar. So, keeping to that temperament around consumerism and how to be innovative, because the next thing is around pricing. Patients want to know what they owe, but honestly, they're not educated enough, and we all know that. So my mother goes to the cheapest mobile, for an MRI, and she doesn't realize that cheaper is not better, and the quality is not there, and it might cost her in the long run. So I want to stress that from a consumerism perspective. So I've covered a lot in a matter of like 5 challenges as a crash course and a Reader's Digest version for this group, but I open the questions, Nikki.
Great. Thank you so much for that, Lyman, for sharing that presentation. Very, very engaging. So before I pick our first question, I would like to just remind everyone to type in their questions using, I know I'm using the word questions a lot, but in that questions chat panel, which is located to the right of your screen, and we'll take as many questions as time will allow. I will address one question about accessing the replay. So I will send, this has been recorded, and we will send this over to the First Illinois chapter, and so that we'll have that replay available for our healthcare community. All right, so our first question is, of the 5 discussed, what do you find as your health system's greatest challenge and why? Hey, Lyman.
Hi.
Hey, did you get that question? Should I reread it for you?
Yes, please.
Okay. So of those 5 challenges you discussed, what do you find as your health system's greatest challenge and why?
I would say patient responsibility. And again, I'll emphasize that I'm not talking about self-pay, because that's going to go through a little bit of change under the different politics, and good, bad, or indifferent. But at the end of the day, the out-of-pocket expense and the ability to support consumerism, meaning what the patient wants to know what they owe, what are their options from a patient financing perspective, and then ultimately treating them in a more patient-friendly manner is, I think, is ultimately which crosses all boundaries in these discussions.
All right, thank you for that. Our next question asks, do you find patient responsibility growing? And if so, how are you addressing this as it relates to enhancing collections and reducing costs?
without question it's growing, and all the statistics demonstrate that, irrespective of, whether it's under Trump care or Obamacare. But it is growing, and I think the bigger challenge is that they're growing in like higher deductible plans and things that on the one slide, I think I demonstrated that patients are more likely to pay a $200 bill versus a $5,000 bill. And they need options to pay that ultimately. So, in today's world, if it digresses into they may owe more out of pocket, what are providers doing to complement that, as well as, the general terminology around consumerism and patient population, et cetera. And patient wellness, let me stress that patients want to continue care, but I strongly believe some patients are reserved about continuing care because of their financial responsibility.
All right, thank you for that. Okay, we have another question that has just come in from Victoria. It reads, how do you suggest providers educate patients about the EOB when the self-funded plan reprices the claim using an off-contract discount that inaccurately shows a patient balance of 0?
Wow, that's a great question, because that's a battle you cannot struggle with. Educating the patient to understanding repricing or third-party payers that intervene is a script in itself. What I would recommend, or she could reach out to me, I've done some scripting around that. We've all had that dangerous mode where somebody will outsource it, even though I said outsourcing is a great option, to a third party will try to say, let's make a deal, or tell the patient they really don't owe anything. And unfortunately for the patient, they don't understand it. So part of it is payer collaboration and relationships, to her question, but she's welcome to reach out to me, and I have some scripting specifically around that challenge.
That's perfect. In fact, Lyman, I believe, if I'm not mistaken, don't you have your information on a question slide? You may want to advance it to that one while we're in the Q&A.
Okay.
That would be great. And while you're doing that, we do have a final question that has come in. Uh-oh. I can put it up there for you.
Okay.
So I'll just go ahead and read it while I'm doing that. So the last question is, are you finding that your clients are tracking their financials in ways that they can make data-based decisions on using third parties and outsourcing?
Okay. So to that question, excuse me, to me, everything's around the return on investment. I'm hoping I understand the question clearly. What I would suggest is there's an operating model that I think should sit out there. The first would be, how do you access the patient, put them through a model of eligibility for Medicaid or any other program or insurance, and then maybe an early out program. And then in that segue, what's your in-house cost to pursue that patient and or insurance after those elements, and then third-party contingency. Each of those should have an ROI of no less than 3 to 1. And there's frameworks around that that says, how do I measure my ROI? And I'm not one to say we're trying to illuminate people and bodies, because there's a big investment training staff much greater than it was 20 years ago when I started in this industry, where you just said, just pay me. It is much more of a training and investment that you've committed to as a provider, and you want to retain those employees and repurpose them as needed. So if you can be more automated and you can demonstrate the return on investment to use a third party, early out or eligibility vendor, you name it, and you can redirect those employees to be more effective, then I think there's a value proposition around that. And I say that with all sensitivity to having 2,000 employees at Cleveland Clinic that Susie had a $5 appointment or a $5 account, and for 6 months would call that patient, and because she was trying to demonstrate goodwill to the organization, but I was trying to demonstrate there's no value to that anymore. And she recognized that, but she was trying to be a committed employee. So I just want to say it's not a demonstration of eliminating costs, but repurposing employee value.
Well said. That makes a lot of sense. Thank you so much for that, Lyman. So as we approach the top of the hour, I do want to take this time to thank our members and the healthcare community for joining us for this call. As you exit, you will be prompted with a survey, and we would greatly appreciate you sharing your feedback about today's event, as well as other topics that you'd like to see in future webinars. So thank you again to our guest presenter, Lyman Sorenberger of Capio Partners. We are so grateful that you took time out of your schedule to not only prepare this, this presentation, but sharing it with our audience. So thank you, Lyman.
Thank you, Nikki.
And on behalf of HFMA First Illinois, thank you everyone again for joining, and have a great afternoon.
Thanks, everyone. Bye.